Hello, my name is Patricia McKinney, and I'm the Bariatric Coordinator for Norman Regional Bariatric Program. This presentation by Drs. Lana Nelson and Andrew Wheeler provides an overview of weight loss surgery. This seminar will talk about how much obesity can affect your health and affect your life. The doctors will discuss various treatment options that are available, and they'll talk about the risks and benefits of surgery. If you think that weight loss surgery might be for you, the doctors provide information about the steps that need to be taken before you're ready for your surgery. Dr. Nelson joined the Norman Regional Bariatric Program in 2005, and she has experience in caring for over 1,000 weight loss surgery patients. She had completed a fellowship in bariatric surgery, and she's published scholarly articles on the subject. She's a board-certified surgeon. She's been a Center of Excellence surgeon since 2007 and helped to found the Journey Clinic, which is now a part of the Norman Regional System. Dr. Nelson is currently the Bariatric Program Director for Norman Regional's Bariatric Program. Dr. Wheeler joined the Norman Regional Bariatric Program in 2013. He has extensive experience in caring for bariatric surgery patients. He too has completed a fellowship in bariatric surgery, and he has presented bariatric research at national meetings and has published in major scientific journals. Drs. Nelson and Wheeler perform their bariatric surgeries at the Norman Regional campus on Porter Avenue in Norman. Norman Regional provides comprehensive care for weight loss surgery patients and has since 2002. Norman Regional is a bariatric center of excellence with dedicated team members who are committed to providing the most excellent care to weight loss surgery patients throughout their stay, from those who are caring for them in the operating room to those who are caring for them on the metabolic surgery unit.
When discussing weight loss therapy, it's important to categorize patients into the different levels of obesity. The ideal BMI is considered at the level of 19 to 25. Obese or overweight patients are considered at a BMI of 25 to 30, and once a patient reaches a BMI of 30, they're categorized as obese. Severely obese patients have reached a BMI of 35, and this initially qualifies some patients for weight loss surgery. Once a patient reaches the morbidly obese category of a BMI of greater than 40, a patient then becomes universally qualified for weight loss surgery as long as the insurance approves that. Super obese patients or super obese patients are in levels of 50 as well as 60 BMI respectively. This is important to consider because as a patient's BMI increases, not only do diet and exercise become less effective, but the amount of weight loss that can be achieved after weight loss surgery does go down somewhat. In addition, studies have shown that complications after weight loss surgery do go up some in the patients in the significantly higher BMI groups. So what are the medical impacts of obesity? Although there are significant psychological benefits of weight loss surgery as well as benefits in achieving weight loss, the main reason that we offer weight loss surgery is because it improves or cures medical comorbidities that exist secondary to obesity. The comorbidities that exist secondary to obesity truly affect every organ system of the body. The respiratory system is affected by sleep apnea, shortness of breath when exercising or going about your daily activities, as well as asthma. Gallstones, heartburn or acid reflux, fatty liver and cirrhosis affect the GI system. Depression affects patients psychologically, secondary to obesity. Cardiovascular implications of obesity, both secondary to diabetes, which occurs because of obesity, as well as secondary to other causes, include things like heart disease, heart attacks, strokes, high blood pressure, high cholesterol, as well as venous ulcers because of lower extremity edema, as well as blood clots in the legs. Morbid obesity also affects patients from a musculoskeletal impact, including things such as osteoarthritis, joint pain, back pain, or gout. Studies have also shown that patients with morbid obesity have an earlier mortality. It's because of these comorbidities that we offer weight loss surgery to try and not only help you from a standpoint of losing weight, and feeling better about yourself, but also truly increasing your lifespan and curing you of multiple illnesses that exist because of obesity. In addition to the medical impacts of obesity, there are quality of life impacts of obesity. Things such as physical impacts, not being able to fit into clothes or fit into furniture, both in social settings as well as at home. Economic impacts, including workplace discrimination and missing work because of the comorbidities. Social implications of obesity, including weight harassment or prejudice because of your obesity. And psychological impacts, depression and low self-esteem that occur when a patient is struggling with morbid obesity. What we know about morbid obesity is that it's a disease. It's a disease that can be treated, and that's why we're talking today. So what are strategies for weight loss? Well, there's dietary strategies, there's physical activity, increasing exercise, behavioral therapies, alternative therapies, as well as pharmacotherapies. Now, what we know about medications, many new medications that come onto the market, is that oftentimes, although they offer some weight loss, they are far inferior to weight loss surgery and oftentimes not sustainable. The New England Journal of Medicine produced a study several years ago from the Swedish obesity study looking at different weight loss options and their long-term effectiveness. And what we know is that diet and exercise alone oftentimes provide a short-term improvement of weight, but long-term do not offer sustainable weight loss. Surgical procedures that were offered at the time, gastric banding as well as gastric bypass, did offer sustainable weight loss over the long term, indicating that these are durable options for helping a patient achieve sustainable weight loss. The vertical band of gastroplasty was also considered in this group, although it is no longer offered because of some of the complications occurring with the procedure. In order to talk about the different procedures that are offered, it's first important to talk about how these procedures are performed from a generalized standpoint. Here at the Journey Clinic, over 95% of our patients and almost all of the patients undergoing primary weight loss surgery are done laparoscopically. What this means is that rather than making a large midline incision to perform the weight loss surgery, it is done through small incisions, which offer better cosmesis, lower comorbidities or lower complications from a pulmonary as well as a cardiac standpoint, earlier return to work, earlier out of the hospitalization, less pain medication requirements. So how does surgery work? Surgery can be categorized into three types of mechanisms by which weight loss is achieved. First of all, there's malabsorption, then restriction and malabsorption, and then restriction alone. The main malabsorptive procedure was the biliopancreatic diversion or the duodenal switch. This procedure is still done at some centers, but it does have significant malabsorptive effects on a patient's life, and so at this time we're not offering it at the Journey Clinic. Instead of the biliopancreatic diversion, we offer other procedures that we feel offer patients with sustainable, near equivalent effects to the biliopancreatic diversion, and these function both by restriction and malabsorption as well as restriction alone. The gastric bypass is the procedure that offers both weight loss through restriction as well as through malabsorption. Not only is the stomach smaller, but because of the intestinal bypass, there's also malabsorption. And it's this malabsorption that probably leads to the significant impacts on diabetes as well as other comorbidities. From a restricting standpoint, there are three main procedures. The vertical band of gastroplasty, as I mentioned, is no longer offered. But the two main ones that we offer here are the adjustable gastric banding as well as the gastric sleeve. The adjustable gastric banding functions by a band creating restriction, and the gastric sleeve, although offering restriction, also does have an impact on hormones, leading to increased satiety in patients that undergo a gastric sleeve procedure. So what are the benefits of weight loss? Well, we've mentioned some of these already, but after weight loss surgery, what we know through extensive literature and extensive research is that patients achieve sustainable, substantial weight loss that is durable over the long term. Because of this, patients have an improved quality of life, an increased life expectancy, improved energy and self-esteem, and we know that patients take fewer medications because of both improvement and resolution in a large number of comorbidities. Comorbidities such as diabetes, high blood pressure, high cholesterol, obstructive sleep apnea, degenerative joint disease, heart disease, as well as many others.
Hi, I'm Dr. Lana Nelson, and during this segment we're going to be discussing the different types of weight loss surgery procedures that are available. We're going to begin by talking about the gastric bypass, sometimes called the Roux-en-Y or the RNY. And what happens during this procedure, the first step is that the surgeon makes a small pouch out of the top portion of the stomach. This pouch is about the size of a golf ball or a medium-sized egg. After the surgeon makes a small stomach pouch, the surgeon then goes down in the small intestine and makes a cut or a division in the small intestine. This part of the small intestine is then brought up to the stomach pouch and connected to the little stomach pouch. After surgery, food passes directly from the stomach pouch into the small intestine. You can see in the image provided that downstream, the portion of the small intestine that was divided is tied back in downstream so that the digestive juices that come from the disconnected portion of the stomach have a place to empty downstream. This is the Y part of the Roux-en-Y gastric bypass. It's from this point forward that the majority of absorption takes place. The gastric bypass is considered both a restrictive procedure, meaning that it restricts the volume of food that you need to feel full or feel physically satisfied. It's also a malabsorptive procedure, and by this we mean that all of the nutrients that you take in are not absorbed by your system. Let's talk a little bit about the advantages and disadvantages of the gastric bypass. The advantages of the procedure are that it provides very consistent, rapid weight loss. Most patients will reach their goal weight within 12 to 18 months following the procedure. In addition, the weight loss is generally sustained. This means that even several years after the procedure, patients are able to maintain their weight loss. It does have an immediate impact on type 2 diabetes, and the reason for this is because when a portion of the small intestine is bypassed, it impacts the way that your body communicates in terms of the food with your liver, and your liver controls blood glucose levels, as well as the pancreas, which controls insulin levels. So by creating a bypass portion of the small intestine, it has an immediate impact on your blood sugars. There's also an improvement in other obesity-related health conditions, such as high blood pressure, gastroesophageal reflux, obstructive sleep apnea, among others. There has also been shown to be an improvement in the overall quality of life. The gastric bypass has been around for many years, so we have a lot of long-term data as well. It's been performed in various methods since the late 1960s. The gastric bypass curbs hunger as well. It decreases production of a hunger hormone so that physical hunger is decreased. Dumping syndrome is another possibility after gastric bypass, and this happens when an individual ingests simple sugars. The small intestine is not used to seeing simple sugars in its concentrated form, so when it's presented to the small intestine, what happens is digestive juices are released to help dilute the sugar, and the side effects of this are intense abdominal cramping, diarrhea, cold sweats, dry heaves. It's truly a miserable experience if you have dumping syndrome, but I will tell you it will keep you away from whatever you should not have been eating in the first place. There's also the possibility of nutritional deficiencies, and that is because of the rerouting of the intestine. There are particular vitamins that are prone to developing deficiencies, and for this reason, you need to understand that you have to commit to a lifetime of monitoring. So even a year or two after surgery, when you've lost your weight, when you're feeling healthy, you feel like you're making great food choices, because of the malabsorption, you still need to have those vitamin levels monitored by your surgeon. The other disadvantage of gastric bypass is the possibility of something called a marginal ulcer, and this is something that can form between the stomach pouch and the small intestine. People are more prone to developing these ulcers whenever they use certain toxic substances that are aggravating to this intestinal lining, and that includes things like the non-steroidal anti-inflammatory medications, also known as NSAIDs. These are medications like aspirin, ibuprofen, Aleve. These medications can be very harsh on the stomach and create ulcers, and so it's generally recommended that you avoid these medications after gastric bypass surgery. Next, we're going to be talking about the gastric sleeve, sometimes called the vertical sleeve gastrectomy. What's done during this procedure is a portion of the stomach is actually removed, and it leaves a small sleeve of a stomach. With this surgery, the surgeon will place a tube down the esophagus into the stomach and then use that tube as a sizing device. The stomach is then divided from the bottom portion of the stomach all the way up to where the esophagus meets up with the stomach, and approximately 70 to 80% of the stomach is removed during this procedure. Since the stomach is removed during this procedure, that means that this procedure is not reversible. The gastric sleeve works by decreasing the volume of food that someone needs to eat in order to feel full. It reduces your stomach capacity. The other thing about the gastric sleeve is that it also decreases the production of something called ghrelin, which is also known as the hunger hormone. So it definitely decreases the physical hunger as well. Since there's no rerouting, malabsorption is much less of an issue with the gastric sleeve. Let's talk a little bit about the advantages and disadvantages of the gastric sleeve. Some of the advantages include that there's no rerouting of the intestine, so this decreases the amount of malabsorption that patients experience. Dumping syndrome is much less common with the gastric sleeve, although it does occur in a small number of individuals. If you are dependent upon anti-inflammatories, the ones we mentioned before, like ibuprofen, Aleve, Mobic, these types of medications that many patients take for joint pain, you will be able to resume these after gastric sleeve. The chances of developing an ulcer are much less after gastric sleeve than they are after gastric bypass. There's also no foreign material that's implanted. For individuals who have inconsistent or inadequate weight loss, there is the opportunity to proceed on with a gastric bypass in the future. And as previously mentioned, it decreases the physical hunger because it decreases the production of the hunger hormone. Some of the disadvantages of the gastric sleeve: it is definitely not reversible. Once that portion of your stomach comes out, it goes into a formalin jar and gets sent to the pathologist. It may worsen reflux, so if you're an individual that has severe acid reflux or heartburn, then this is not the best option for you. And as far as data on the gastric sleeve, it's been used as a primary weight loss procedure for about 5 years. So we don't really know the durability of the procedure when it comes to 10, 15, or 20 years down the road as we do with some of the other procedures. Let's talk next about the adjustable gastric band, frequently called the lap band. With the adjustable gastric band, a small band is placed around the upper portion of your stomach. This creates a stomach pouch, which ideally restricts the volume of food that an individual consumes in order to feel full. The band can be adjusted. It's connected via tubing to something called a port, and the port sits underneath the skin on the muscle of the abdominal wall. And in the office, a special needle can be placed in order to adjust the amount of fluid that's in the band. As fluid is added to the band, it increases the restriction, meaning that the amount of food that can be consumed is decreased. Let's talk a little bit about the advantages and disadvantages of the lap band. The lap band is considered to be reversible. The band can be removed and the anatomy can be restored. There's also no malabsorption with the gastric banding as the food goes down its normal digestive pathway. It is considered to be the least invasive as there's no cutting of the stomach or rerouting of the intestines. It's generally done as an outpatient procedure, meaning that the patient comes and goes home on the same day, and the return to work is much more quick with the gastric band. Some of the disadvantages of the gastric band: it is considered to be a higher maintenance procedure. It does require more frequent office visits for adjustments to the band. In addition, it may cost more than some of the other procedures over the long term because of the increase in office visits and also because of the adjustments to the band. For individuals who have esophageal reflux, it may worsen the reflux or heartburn and may cause dilation or stretching of the esophagus as well. There's also a higher possibility of reoperation with the lap band, and this is for a number of different reasons. This includes something called a slip, which is where the stomach actually slips up through the band, and that can cause an obstruction or blockage in the stomach. Or if there's problems related to the tubing itself, if the tubing kinks or breaks, or if the port is released from the muscle and turns over and so it's inaccessible. These are all reasons why the band may have to be removed or surgery to correct the system in the future. The weight loss with the adjustable gastric band is more variable than it is with the other procedures. There are some people who do really well with weight loss, but on average, the average weight loss expected is less with the band than with procedures such as the gastric bypass or gastric sleeve. It is considered to be more effective for lower BMI patients, meaning those patients who perhaps don't have as much weight to lose. A well-adjusted band is what we sometimes refer to as your sweet spot. We expect monthly visits for the first year after surgery. You will not necessarily have an adjustment to the band at each of those visits, and it's a good goal to plan on losing 1 pound to 2 pounds a week during the first year. You should be able to eat most solid foods. If you are unable to eat solid foods, then your band may be too tight. You do have to thoroughly chew your food and eat very slowly. If you're someone who's used to eating on the run, you won't be able to do that with this procedure, because if you try to eat your meal in 5 minutes, you're going to spend another 20 minutes in the bathroom wishing you would have just taken your time in the first place. You should be able to comfortably eat a solid meal, primarily for lunch and dinner, and the majority of the time you'll be using a protein shake for your breakfast. There's no limitation of liquids except during your meals. You will not be able to drink while you are eating, and no high-calorie liquids. If you're consuming high-calorie liquids, as there's no restriction for this really defeats the purpose of the band, as you're getting a lot of empty calories, which can sabotage your weight loss results.
As a patient considers surgical weight loss, it is important to understand the risks that are potential when a patient undergoes weight loss surgery. We categorize these risks in early and late categories of the risks that occur and the complications that occur after weight loss surgery. Early complications after weight loss surgery include such things as death, which is very infrequent, blood clot or pulmonary embolisms, also very infrequent, bleeding or significant requirements for blood transfusions happening less than 1 to 2% of the time, injury to the adjacent organs that are in the area that we are operating on, pneumonia or atelectasis that occurs anytime a patient has major abdominal operation, infection that occur both in the incisions as well as on the inside in the form of an abscess, leakage or perforation, more specific for the gastric bypass and the gastric sleeve, as well as obstructions or blockages that can occur anytime two pieces of intestine are connected together. Late complications include such things as low blood sugar because of how the body now processes sugars after weight loss surgery, bone loss or osteopenia due to vitamin D and calcium deficiency, transfer addiction that occur as a patient no longer has a desire to eat food and so therefore becomes addicted to other substances such as drugs or alcohol, suicide, which has been shown in some patients to be at increased risk after weight loss surgery, hernia formation both at the incisions and the abdominal wall, which are rare because of the fact that these are performed in a laparoscopic manner, but also hernias on the inside after the gastric bypass as the patient loses weight and creates hernia defects in areas of fat that were connected together at the time of surgery. A need for additional surgery because of many of these complications, ulcer formation, especially patients who smoke or use anti-inflammatory medications after the gastric bypass are at a significantly higher increased risk. Consider this weight loss journey and what procedure you want. It's important that you have the opportunity to compare the procedures side by side to make a decision about which procedure is best for you. The key thing to remember is that not every procedure is appropriate for each person, and that it is an individual decision made in consultation with your surgeon, but that at the end of the day you need to make the decision about which procedure you feel, based on you knowing yourself more than anyone else, is going to be the most beneficial procedure for yourself. In looking at consistent weight loss, the gastric bypass and the gastric sleeve have been shown to have consistent across-the-board improvements in weight loss. The gastric band is much more variable in its weight loss in patients, and most likely occurs because the band is not put in the properly chosen patient. NSAID use is prohibited after gastric bypass because of the high risk of ulcer formation at the anastomosis between the stomach and the small intestine. However, in a patient that does require NSAIDs after the gastric sleeve or the gastric band, these still can be taken. In terms of the procedures that control hunger, not only because of a smaller stomach and increased satiety after eating, but with a baseline decreased hunger, are the gastric sleeve and the gastric bypass. The gastric band does not have the same effect on controlling hunger. However, in the patients with a properly adjusted band, they do achieve sustainable satiety when eating. Anytime a patient considers surgery, it's important to understand which procedures are reversible. Now, this should be set in the context that although these procedures may be reversible, it is a very complicated procedure with increased morbidity as compared to a primary bariatric procedure. The gastric band as well as the gastric bypass are in theory reversible, whereas the gastric sleeve can be converted to a gastric bypass if a patient has complications or needs to achieve more weight loss. However, it is not per se reversible. Both the gastric bypass and the gastric sleeve have good sustainable relief of diabetes as well as other comorbidities. However, the gastric band has less consistent relief of comorbidities. The gastric bypass also improves or cures gastric reflux in the majority of patients. However, the gastric sleeve and the gastric band do not achieve this improvement of acid reflux because of the way the procedures are performed. And in fact, people that have severe acid reflux requiring multiple medications or medications multiple times a day, the gastric band and the gastric sleeve are not ideal procedures because in a small subset of patients, their acid reflux can actually become debilitating after these procedures. Long-term data is present for both the gastric bypass and the adjustable gastric band and is only now becoming present for the gastric sleeve. Because of this, the gastric sleeve, there's less data well known in terms of the long-term 20-year data on how patients will do, both from a standpoint of complications as well as from a standpoint of sustainable weight loss and improvement of comorbidities. However, the longer time goes, the more we know that the gastric sleeve is becoming very effective and nearly equivalent to the gastric bypass. So when you're looking at surgery, what do you need to do to prepare for surgery? Not just after you come to see the surgeon, but even in the meantime. Well, we want all the patients to be up to date on their screening tests because many of these tests can become much more difficult as you're recovering from weight loss surgery. If you're over the age of 50, we would like for all the patients to have a colonoscopy. Women over the age of 40 should have a mammogram. Women should be up to date on their gynecological exams. And all patients should stop smoking or using tobacco products, as this will prevent you from having weight loss surgery because of the significant side effects that using tobacco products or smoking can have after weight loss surgery. All patients should stop consuming alcohol because patients who do consume alcohol after weight loss surgery have been shown to have increased complications from a psychological standpoint. We also want all patients to attend our Norman Regional Support Group. It's important that you meet other people that are going through the same process or who have gone through the same process as you have to improve your understanding of the process, and also have people that you can reach out to if you experience any difficulties. And the final thing is to get moving, to increase your physical activity, as this will help you in the long term achieve better results after weight loss surgery. So what are the side effects of weight loss surgery? What can you expect after you've had weight loss surgery, in addition to the potential for the risk factors we talked about? Well, some patients will get nausea and vomiting, especially if you eat or drink too quickly. Some patients will experience gas or bloating as the body is trying to adjust to a new way of processing foods because of the fact that your gastrointestinal system has now been modified. Some patients will develop lactose intolerance, diarrhea, and some patients will develop constipation. It's hard to determine whether you will have diarrhea or constipation or have neither of these after weight loss surgery. Some patients, because of the rapid weight loss, will form gallstones, and this can be treated as these occur. We don't take out the gallbladder prophylactically at the time of weight loss surgery because of the known risks of gallbladder surgery. However, if you do develop symptomatic gallstones, we can take out your gallbladder to treat those symptoms at the time. Patients do experience hair loss and thinning because of the protein deficiency that occurs after weight loss surgery, and it's usually not until a patient achieves the plateau of weight loss that their hair loss or thinning will reverse, because then at that time the body can use those protein stores to not go towards the essential organs, but to improve your hair quality. Patients can develop nutrient deficiencies, which is why we put patients on lifelong vitamins after weight loss surgery. Loose skin will occur as you lose weight. In some patients that can tighten up, but in other patients may wish to explore cosmetic surgery after weight loss surgery because of the loose skin. Some patients will develop depression due to the drastic changes in their life with weight loss and the relief of their illnesses, as well as psychological distress because of the new changes in life. Any females who are of childbearing age who are interested in weight loss surgery need to understand the implications of weight loss surgery as it relates to pregnancy. Pregnancy should always be avoided until you discuss and are cleared by your bariatric surgeon to become pregnant. Pregnancy can become very dangerous in a patient who is still losing a significant amount of weight and has a protein deficiency, both on the mother as well as the baby. Weight loss and nutritional intake need to have stabilized before you're interested in becoming pregnancy, and this usually occurs about 18 months to 2 years after surgery. In the meantime, all patients who are of childbearing age, females, should be on two forms of birth control in order to prevent pregnancy.
During this segment, we're going to talk about a typical hospital course. We'll also talk about some of the things that you can do in preparation for surgery and some of the expectations for you after surgery. For gastric bypass or laparoscopic gastric sleeve, these surgeries typically last an hour to 2 hours. A typical hospital stay is 2 nights in the hospital, although some patients do stay a little bit longer than this. And most individuals will take about 2 weeks off of work. If you are very physically active in your job and have a lot of physical responsibilities for you in your job, you may have to take a longer period of time off. The adjustable gastric band or lap band generally takes about 40 minutes. Most individuals will have this procedure done as an outpatient surgery, which means you'll be able to go home on the same day, although some individuals do have to spend overnight in the hospital. If you have a desk job, you can expect to be back to work about a week after surgery. Your diet in the hospital generally consists of clear liquids, and as you go home, you'll transition to something that we refer to as full liquids, which is basically a protein shake consistency diet. As far as your journey to surgery, you've completed the first step by watching these seminar videos. The next thing that you need to do is complete your seminar paperwork. If you have a problem finding this on the website, please call our office and our assistants will help you. After you have completed your paperwork, our office staff will verify coverage for weight loss surgery with your insurance company. Then you'll have the opportunity to come in and meet with a surgeon. When you meet with a surgeon, we'll discuss which particular procedure you're interested in. And if you have a difficult time deciding, don't worry, we'll help you with that decision. We will also then schedule you for some preparatory visits. The main preparatory visits that everybody has to complete include a visit with a psychologist, a registered dietitian. You'll attend a support group meeting, and you'll also meet with a physical therapist. All of these things are designed to prepare you for your weight loss journey. There are some additional testing that we may ask you to do, and this depends upon your individual situations. Some of the common requests include the visit with a cardiologist, a sleep study, and other things such as this. After you've completed the entire plan, then you'll come back into the office to meet with either the surgeon or the physician's assistant to ensure that you're ready for surgery. At this point, we'll schedule your surgery. We'll also schedule something called a prep diet and prep class. This is the point at which you learn what happens start to finish while you're in the hospital, and you also learn about a preparatory diet that prepares your digestive system for surgery. Once you've completed this, then approximately 2 weeks later, you will have your surgery date. After surgery, we expect that you're going to have regular follow-up with us at Journey Clinic. The expectation for most patients is that we'll see you at 2 weeks following your surgery date, again at 6 weeks, at 3 months, at 6 months, and then again annually. If you are a band patient, remember that you will be coming in for monthly visits that first year after surgery. During your visits, we will be monitoring your weight loss, your compliance with your diet, your compliance with your physical activity, and we'll also be doing some nutritional monitoring. We also think it's a good idea for you to attend support groups. The support groups are helpful for providing expertise and experience from other patients, providing support that you may not necessarily be able to get from friends and family members who don't completely understand what you're going through. We also request that you contact your surgeon's office for any problems related to your abdominal area after surgery. If you're having problems with abdominal pain, increased reflux, vomiting, it's very important for you to let your surgeon know, as your primary care provider or a surgeon who's not experienced with weight loss surgery may not be familiar with all of the problems that can arise after weight loss surgery. Please keep us in the loop. Just as a reminder, your visits with your surgeon do not replace your regularly scheduled visits with your primary care physician. It is not our intent to replace your primary care physician, but we do need to follow up on your weight loss progress as well as your nutritional status. Just a few final thoughts as you're considering your weight loss journey. Surgery is not a quick fix. It does not come without risk. It's certainly not for everyone. If you're not mentally and physically prepared for the surgery, then you may not have the outcome that you wish. Surgery is only a tool to help you lose weight. If you do not make changes in your behavior for the long term, then you can expect that you may regain weight over a period of time. It's important to understand that surgery will help you get to where you may be unable to get to on your own in terms of your weight loss goals. However, you have to make changes in order to maintain those weight loss goals. Surgery is the most effective treatment that we have for morbid obesity, and it confers the best long-term weight loss. Thank you for joining us for our seminar videos. We look forward to meeting with you soon.